Hi, I'm Marvin Natovich. I'm a medical geneticist here at the Cleveland Clinic and a professor at the Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. We're fortunate today to be able to talk with Dr. Mark Korson. Dr. Korson is a specialist in medical genetics and metabolism. He graduated in medicine from the University of Toronto, and he completed residency training in pediatrics at the Hospital for Sick Children in Toronto. He then went on to do a genetics and metabolism fellowship at Children's Hospital of Boston and subsequently directed the metabolism clinics at that institution for about 10 years, followed by directing metabolism services at Tufts New England Medical Center for about 14 years. About 15 years ago, Dr. Korson co-founded a unique and very important program, the Society of Inborn Heirs of Metabolism North American Metabolic Academy, which is the premier conference or training for genetics and metabolic trainees in the United States. 5 years ago, Dr. Korson joined an organization called VMP Genetics and became its director of physician support services. And he pioneered a truly unique consultative service that provides remote assistance to clinicians at about 12 major U.S. academic medical centers in the area of metabolism, where he provides guidance about patients with suspected or proven metabolic diseases. And this is extremely important because there's a worldwide shortage of persons with expertise in clinical metabolism, especially relating to genetic metabolic disorders. At that organization, Dr. Korson is also director of education, and in that area as well, he's distinguished himself. He's developed some truly innovative, both in-person as well as virtual educational programming about metabolic disorders for both non-genetic physicians as well as for various healthcare professionals who are not physicians who work in metabolic clinics so that they can play a larger role in patient diagnosis and management for patients who have genetic metabolic concerns. Dr. Korson also directs a very interesting and important patient-teacher registry and patient-teacher video catalog. And the aim of these interesting endeavors is to ensure that patient voice plays a role in educating healthcare professionals relating to genetic metabolic concerns. So here we are today, and we have Dr. Korson with us, and we're going to go through a clinical case that touches upon metabolic dimensions of autism. Thank you so much for being here today.
Thank you for inviting me.
Yes, so this particular case is a hypothetical case involving an 8-year-old female who was referred to a medical genetics clinic because of intellectual disability, autism, hyperactivity, and seizures. This hypothetical child was the product of an uncomplicated full-term pregnancy, labor, and delivery to a healthy 26-year-old mother and healthy 27-year-old father. The child's birth growth parameters were unremarkable, as were the APGAR scores. The neonatal period was also unremarkable. By about 6 months of age, it was noted that this child was having some developmental delays. She wasn't smiling at that time. She didn't consistently attend to the voice of her parents. She wasn't laughing or squealing, and she wasn't reaching for toys. At about 2 years of age, she developed a generalized seizure disorder, and she was treated with an anticonvulsant. At about 2.5 years of age was when she began to walk independently. By 3 years of age, she was able to speak a few words, and she was noted to be very hyperactive then. She underwent a detailed neurodevelopmental assessment then, and she received a formal diagnosis of autism spectrum disorder, intellectual disability, attention deficit hyperactivity disorder, and generalized epilepsy. Some diagnostic testing was done at that time, and that included normal results for a complete blood count, blood ammonia, blood lactate and pyruvate determinations, and urinalysis. A comprehensive serum chemistry panel was also done, and the electrolytes, glucose, calcium, liver function tests, and BUN were found to be within the normal reference intervals for the child's age. The creatinine wasn't flagged, but it was 0.04 milligrams per deciliter. In other words, it was quite low. Other diagnostic testing done at that time for this 3-year-old child included a normal chromosomal microarray analysis and a negative Fragile X syndrome test. She underwent a cranial MRI, and it did not show any structural or anatomic abnormalities, but there were signal changes in a region of the basal ganglia called the globus pallidus. Bilaterally, there was a hyperintensity in that part of the basal ganglia. In terms of the family history, both of the parents were healthy and unrelated, and a 3-generation family history was entirely non-contributory. Now she's 8 years old, and at this point in time, this girl could speak a few single words. She made brief or fleeting eye contact, and there was very little reciprocal interaction between her and another person. She appeared non-dysmorphic. She had mild short stature with her height measuring at about the 3rd percentile for age, and she was underweight with her weight measuring at about the 2nd percentile for age. The remainder of the general physical examination was unremarkable. Her neurological examination was notable for her neurodevelopmental phenotype, which I have mentioned, as well as motor stereotypies. So my first question to you, Dr. Korson, is, are there any particular comments that you would like to make about this case? Are there ways that you would like to discuss with the viewers about how you conceptualize the pieces of information that I've given you so far?
Mm-hmm. No, thank you, Marvin. I guess I look at patients who are referred because of problems that include or that are autism or include autism. Is the problem autism, or and there's really no other particular major issues in which one might call that isolated autism or non-syndromic autism, because it matters how I approach those patients, and to make sure that, and to confirm that it truly is isolated autism, is you really have to do an exquisitely extensive review of systems to make sure that you have properly characterized the entire phenotype. And on the other side then is syndromic autism. Autism in patients who have more than just autistic features, who have neurologic features, who have behavioral problems, who have problems in other organ systems, in which case the autism is part of a larger issue. And those patients have to be considered in a different way. Now, so that's, I guess, point number one for me about this case. The other point is, for many metabolic disorders, growth becomes an issue, whether it's because of the underlying genetic disorder, whether it's because of inadequate nutrition, whether it's because of behavioral problems which narrow the diet opportunities or options for certain patients. But I noticed that at birth, the child was normal or unremarkable, the growth parameters, but by 8 years, the weight and height are very much at the lower percentiles. When did that happen? Was that more recently, which then could be something nutritional, or has it been very gradual over time, in which case maybe that's more related to the genetics of the underlying disorder? So that's one point. And the third point that stands out is these hyperintensities in the globus pallidus, in the basal ganglia. And that makes a metabolic doctor like me really perk up, because the basal ganglia, the deep nuclei of the brain, which are partially responsible for regulating how we move in with very specific calculated movements, that we don't overshoot, we don't, our tone is appropriate, and so on. Those deep nuclei are sensitive to problems with energy in terms of energy supply, and they are also sensitive to intoxication. So if you look at patients with mitochondrial disease, or the so-called Lee disease variant of mitochondrial disease, where you have lesions in the basal ganglia, you have very characteristic bilateral, so involving both sides, on both sides, and so they're almost symmetrical lesions. And in that particular disorder, because it's a progressive disorder, over time you may see additional lesions over time. Now, in this case, I don't know if I see progression here, and there's not an indication of multi-system disease like you might see in mitochondrial disease, but that still remains a possibility here. In metabolic medicine, organic acidemias are another area where you can see these symmetrical lesions in the basal ganglia, of which, by the way, the globus pallidus is just one part. But you can see it anywhere, actually, in the basal ganglia. And when in that group of disorders, there is intoxication by the actual organic acids, but also those disorders are associated with, those patients have real energy problems as well that resemble, actually, mitochondrial disease. And so you see those same lesions. But there's one third category of disease, and that is one of the creatine synthesis disorders, guanidinoacetate methyltransferase deficiency, where you actually also see these lesions in the globus pallidus specifically. And that may be due to the toxicity associated with the accumulated metabolite called guanidinoacetate. So those are my preliminary thoughts on this case.
That's really interesting. So even with the small amount of material that I've presented to you, you've already honed in on a few categories of clinical considerations.
But don't, as doctors want to do, you want to try to make a quick and fast diagnosis, not with these disorders. You can think ahead, but be willing to revise your thinking as you get more information.
Beautiful. So with that thinking, what in general are some of the commonly used metabolic screening tests for persons who, like this child, have unexplained intellectual disability, with us being pushed somewhat in the category of an underlying metabolic process, partly because, as you mentioned, you have bilateral, roughly symmetric involvement of a certain area of the brain.
So I am going to talk first about unexplained intellectual disability without the lesions per se. Because in both the organic acidemias and mitochondrial disease, you may not have those lesions. To that end, one has to remember that metabolic disorders are multisystemic, and therefore a screen should kind of take a look at the various organ systems. The basic laboratory, the simple laboratory tests that I would think about are take into account those metabolic disorders that can affect blood. So I would do a CBC and differential that can affect glucose and lactate metabolism. So I would get those that affect functioning of the liver and of the kidney. I would get a creatine kinase level and uric acid. And finally, I would do urinalysis as well. And so those are the kind of the simple tests. In addition, I would get an ammonia level, because that can cause an encephalopathy, which can actually be quite variable and almost intermittent sometimes, and homocysteine, because that's involved in disorders more than just the classic homocystinuria syndrome, but other disorders associated with intermediary metabolism. Thyroid functions, very treatable, and now when I talk about the metabolic testing in blood and urine, I'm paying attention to particularly the treatable disorders that, again, you want to make a diagnosis in everybody where it's possible, but you want to make absolutely sure that you're identifying the treatable disorders and you're not losing time there. So in blood, I would test for amino acids and acylcarnitines. I would screen for certain disorders of congenital disorders of glycosylation. And there's probably like 140 of these disorders now, on how the body creates glycosylated proteins and glycosylated lipids. There are actually many disorders now in that group that are treatable. So I would do isoelectric focusing of transferrin. That is not a transferrin level. It's a specialized way of looking at transferrin. I would get copper and ceruloplasmin to consider Wilson disease. Very treatable, presents with liver disease, but in older individuals, the liver disease may not be florid, but the patient presents with neurologic problems and psychiatric and behavioral issues. And then finally, very long-chain fatty acids as a screen for X-linked adrenoleukodystrophy, where the presentation can be very behavioral. In urine, I would get urine organic acids. I would screen for cerebral creatine disorders, where the body does not produce enough creatine, and the screening test looks at urine creatine, but also urine guanidinoacetate. And then for disorders of lysosomal storage, glycosaminoglycans and oligosaccharides. Now, having said all that, these group of tests were selected because diagnosis through using these tests is good, but also because a lot of the disorders we're talking about there are treatable. However, if you look at the group of metabolic disorders as a whole, there are disorders of small molecules, which is intoxicating disorders like urea cycle disorders, where ammonia intoxicates the brain. There are energy disorders like mitochondrial disorders, where the body does not make enough ATP energy, or it can't mobilize substrate for energy production like glycogen storage disease or fatty acid oxidation defects. You can't mobilize those to make ketones and glucose. And then the other group are disorders of complex molecules, which is the fastest growing group of disorders in metabolic medicine, and now contains more disorders than are described in either of the other two groups. And these are disorders, for the most part, that have no biomarkers, like there is in PKU and phenylalanine, like there is, in glycogen storage disease, where you have particular patterns of low glucose and high lactate. There's no biomarkers, so there's no good way of testing for them, and you'll never find them unless you actually order whole exome sequencing or whole genome sequencing, where you find the pathogenic mutations, and that cinches the diagnosis. Now, just a word for ordering those comprehensive molecular tests, and that is that laboratories who are seeing some of these DNA changes for the first time may not know whether the alterations in the genes are in fact pathogenic, or they are associated with polymorphisms or benign changes, in which case, where possible, if you're going to use the whole exome or whole genome route, if you find an abnormality for a disorder that does have biomarkers, then you should have to prove the functional abnormality of that gene by actually doing the functional test. So if you find that a patient has PKU, for example, and they've identified pathogenic mutations, you have to do amino acids to document that the phenylalanine is in fact high.
Good. So, are there, at this point in time, any specific metabolic tests that are universally recommended in the diagnostic evaluation of persons with autism, children or adults with autism, as a matter of standard medical practice?
Are we talking about isolated autism, or are we talking about syndromic or complicated autism?
That's a good point. Let's first start with isolated autism.
Well, so this has been looked at by researchers and clinicians who are interested in this area. And when you look at all the testing that has been done to try to identify a diagnosis with a lot of metabolic test panels, they actually haven't been able to say with any conclusive evidence that there's a good cost-benefit ratio, that they've actually identified patients and it's worth doing the testing. Now, this is an ongoing research question. So because there isn't a final decision, some clinicians may still opt to do testing. But at this point, there is no society that I'm aware of, academic society like neurologists or geneticists, that would recommend testing in the isolated autism population, unless there are
Metabolic testing.
Metabolic testing, I'm sorry, in the isolated autism population, unless there are other clinical features which take it out of the isolated area, unless there's a family history of similar problems suggesting there is something genetic in the family, and some might say, if the patient never underwent newborn screening, which is a metabolic screen of sorts, you want to give the patient at least that testing experience.
Great, that's very helpful to know. in this particular case, you went through and provided a really meaty listing of clinical conditions and tests for those conditions that are metabolic tests and metabolic considerations for persons with unexplained intellectual disability. For this particular child, who is now 8 years old, who has intellectual disability, autism, hyperactivity, and epilepsy, and has the neuroimaging findings that we mentioned, where there's bilaterally symmetric findings in part of the basal ganglia, is there any specific metabolic testing at this point that you think would be reasonable?
So if the differential diagnosis of the bilateral hyperintensities, including the other features, neurologic and behavioral features that you mentioned, I'm thinking mitochondrial. And mitochondrial, when one says mitochondrial disease, there are hundreds of disorders, and with a huge range of phenotypes. So this could satisfy that. But speaking against it, the fact that there isn't clear progression, which one might expect to see before the age of 8, so it's just a thought. The organic acidemias was second in the differential, even though there are some organic acidemias that can have a chronic course to them, and children don't fall apart. It is unusual in 8 years that the child hasn't decompensated with an intercurrent infection and doesn't have any of the simple tests that, or abnormal results in the simple tests like a low bicarb or a high anion gap or a highish ammonia or something. So I think it's less likely. And then the third group are the creatine disorders. And these disorders are worth considering because the more common of the three groups, which is guanidinoacetate methyltransferase deficiency, when you look at that population, the onset of disease is usually between 6 months and 2 years. That fits. These patients have intellectual disability, they have seizures, they have behavioral problems, and they also often have movement disorders, and this child fits the bill. And those children have problems in lesions in their globus pallidus. So the two I would test for are mitochondrial and creatine disorders. The truth is mitochondrial disorders, it's hard to rule out completely, and it's very expensive. It requires it requires evaluation of nuclear encoded mitochondrial diseases, which would be whole exome sequencing as an example, and then mitochondrial DNA testing to look at that DNA. I would start with creatine disorders first. If that's negative, move on to a mitochondrial evaluation.
Okay, thank you. That was done in this particular case. This child had a urine organic acid test that was unrevealing, had blood lactate and blood pyruvate that were unrevealing, plasma amino acids that were normal, including the blood alanine, and in terms of the disorders of creatine synthesis that you mentioned, this child had a pathologically elevated level in the urine of guanidinoacetate and a pathologically low level of creatine, which would be consistent with and probably indicative of one of the conditions that you mentioned, guanidinoacetate methyltransferase deficiency. And you'd mentioned that this particular condition could be consistent with the clinical story of this person. Is there any confirmatory testing that you would do And if so, why?
Well, so I guess, I'm going to make one point. You, in your question, you talked about the normal lactate and pyruvate and alanine on blood amino acids, the kind of thing we might see in certain mitochondrial disorders. But I just want to make sure that the viewers know that not all mitochondrial disorders are associated with high or disturbed lactates or high alanines. And it's one of those tests that if you find it, it can be helpful. If you don't find it, it doesn't rule out anything. And then, so the creatine disorders are a good test. It's the biomarker test, the urine test, is a good way of screening for these disorders. And the two things are guanidinoacetate and creatine. Depending on what is high and what is low, can point towards the specific diagnosis. So for the guanidinoacetate methyltransferase, the block is after guanidinoacetate, that's high, creatine is low. For the more proximal arginine glycine amidinotransferase, the guanidinoacetate is low and the creatine is low. And if you have a creatine transporter problem, where you actually make creatine, but it doesn't get to where it needs to go, the creatine in the urine is actually high because it's lost in the urine, and there's no problem with creatine synthesis, so guanidinoacetate is low. Once you identify the problem, because it's a familial, or it's a genetic condition, often one would confirm it with molecular testing, so that if there are any concerns about other patients, other people in the family, then one would go for the molecular test for testing in the family.
And what is the importance of this pathway? What is the importance of a pathway in the human body so that creatine is made and then can be transported into various cell types? Why do we need this pathway and have a metabolic disorder that can result in intellectual disability, autism, sometimes seizures, if this pathway is mucked up?
Well, creatine is intimately involved with energy supply in the body. So ordinarily in the cells, ATP is one of those molecules that fuels chemical reactions. And in doing so, ATP is converted, after it gives away its energy, it's converted to ADP. Well, you can't have a system in muscle or brain, both very high energy consuming organs. You can't have a situation where ATP levels are running low in the cells. You need some system that converts the ADP back to ATP. And that's where creatine comes into the picture. Creatine is synthesized in the gut, in the liver, and then it is sent out to the cells, muscle, brain, and other cells. And there, in those cells, creatine kinase, CK, adds a phosphorus to the creatine to make phosphocreatine. Phosphocreatine then is the observer of ATP. When ATP is converted to ADP in ordinary homeostasis reactions, phosphocreatine gives its phosphate group to ADP to make ATP, so that ATP levels are actually relatively constant in cells. The levels of phosphocreatine may vary and fluctuate, but not ATP, and that guarantees that you don't fall apart every time you exert yourself. So we have to give thanks to phosphocreatine for serving that function.
And now that the underlying etiology of this child's intellectual disability, autism, and other major issues is better understood, is this potentially a treatable disorder by metabolic means?
The answer is definitely yes. And I would spend just a minute on the biochemistry because the treatment is integral to the biochemistry is integral to treatment. So creatine is formed from glycine and arginine, and the enzyme brings those two together, and it creates guanidinoacetate and ornithine. And then guanidinoacetate is converted to creatine. So the block in guanidinoacetate methyltransferase deficiency is between guanidinoacetate and creatine. If you restrict the amount of glycine coming down, then you will reduce the amount of guanidinoacetate that is formed. Remember, guanidinoacetate, when it accumulates, is actually toxic. So by reducing glycine with sodium benzoate, binds glycine and gets rid of it, you're going to reduce the amount of accumulating guanidinoacetate. If you reduce the amount of arginine, with, say, a low arginine or a low protein diet, you reduce one of the substrates that leads to the accumulation of guanidinoacetate. A low protein diet is actually difficult. It's very intrusive. So what is done often is give large doses of ornithine, which is one of the products from that initial enzyme that makes guanidinoacetate and ornithine. Give large amounts of ornithine, which actually inhibit the enzyme that makes it. So it reduces the production of guanidinoacetate. And then finally, the problem is not only the guanidinoacetate toxicity, it's also the synthesis, the formation of creatine. So these patients are supplemented with large amounts of creatine. So reduce the toxicity and provide the product. The response to treatment is good. There are documented improvements in intellectual disability that can impact behavior, language, activities of daily living. And even if a patient is severely disabled, they can still show improvement. So even if this patient is 8 years old and therefore has had this disease for most of her life, she might still respond to therapy. Of course, it's better that these patients are identified as early as possible so treatment can begin at that time. But still, even late diagnosed warrants a trial of therapy. And by the way, now guanidinoacetate methyltransferase is approved as a core disease for newborn screening in the United States.
Very interesting. Well, this is really helpful to know. One final question that goes beyond just this particular case and looks more globally at the issue of metabolic issues in autism. For the viewers of your session, Dr. Korson, who are pediatricians, internists, family practice docs, psychiatrists, and still other types of clinicians, what are the take-home messages you would want those clinicians to know about when they should be referring their patients with autism to be seen by a specialist in clinical metabolism?
Okay. If you have a patient with autism and through an extensive review of systems, seem pretty certain that there's nothing else going on, just autism, then there's no benefit in referring the patient to a metabolic doctor, we're not going to find anything significant based on the studies that have been done around that scenario. If, however, you have a patient with autism who also has intellectual disability, or who also has neurologic problems like a movement disorder or seizures, that's a population where we do find diagnoses. And of course, if there are other members in the family who have the same problems that your patient has, there's definitely something genetic in that family which might be metabolic. So those are the three scenarios that warrant a metabolism referral.
This is really helpful. Thank you so much.
I'm happy to be here.